What is immunoparesis?
Immunoparesis is something that happens in patients, can even start in MGUS already, where we see that if a patient, for example, has an IgG, myeloma or MGUS, when the other immunoglobulins are reduced. We know that the plasma cells in the bone marrow take up some space, but there seem to be even other effects of the myeloma or the MGUS cells on the rest of the bone marrow. And we see that the healthy plasma cells that are supposed to produce this other IgA, IgM, whatever is the healthy part, that they are reduced in their function. So if, for example, IgG patient has a reduced IgA or IgM, that we call immunoparesis. The same is true of an IgA patient who has reduced IgG or IgM, and same for IgM.
Why does immunoparesis occur?
Immuno is the immune system, and paresis means weak. So the immune system is weak. So first, let's talk about why it happens. And second, we can talk about why it matters. A couple of reasons. I think the biggest reason why immunoparesis can happen is that, normally we have all sorts of functional plasma cells. Plasma cells are immune cells that make antibodies. Antibodies help protect us against infections. They mount our response to vaccines. Sometimes antibodies also can mediate autoimmune disorders. They're not always good, but typically they are helpful. In multiple myeloma, if so much of the nutrients in the bone marrow are going towards these dysfunctional or these cancerous plasma cells, the normal plasma cells don't have enough nutrients to actually produce what they're trying to produce. And so you might end up with low levels of functional antibodies. For most patients with myeloma, that antibody, the M spike, the M protein, the abnormal protein that we see on the SPEP, that is an antibody, but it's not actually binding to anything. It's not doing them any good. It's not actually helping protect them in any way or form. If anything, the sheer number of resources going towards those myeloma cells is preventing the normal immune cells from functioning. So some patients can have immunoparesis at diagnosis, and that can either be, as I alluded to, a blood finding, just with the immunoglobulin G being low, or it can be that some patients are diagnosed in the setting of having frequent infections. Many, many years ago, actually, that was actually considered a myeloma-defining event, just to have many infections. That is no longer considered to be myeloma-defining by itself, because many patients can have frequent infections for other reasons. But some people can have a diagnosis. Many of our treatments cause immunoparesis. So, the nice thing about myeloma therapy is that for most patients diagnosed today, at least their infection therapy is chemotherapy-free, right? We're not giving true classical chemotherapy for the first 4 to 6 months of therapy. So these patients are not losing their hair. We're not trying to slam the bone marrow and kill everything that moves, because we're using precision targeted therapies that only attack plasma cells. Unfortunately, again, as I alluded to, plasma cells can be both good and bad. The bad plasma cells are the cancer. I want them out. The good plasma, that's the myeloma. The good plasma cells that are making good antibodies that help fight infections and so forth are also getting knocked out by bortezomib, by lenalidomide, Velcade, Revlimid, and so forth. And so, by daratumumab, Darzalex can do it too. And so many patients become hypogammaglobulinic, that's the other word for this, or develop immunoparesis following therapy. CAR T is another good example where CAR T therapy very potently knocks out normal plasma cells as well. Those patients may be at risk of infection. So that's kind of treatment-related immunoparesis.
How is immunoparesis managed?
What do I do about it in that case? Those are the patients where I may recommend, for example, more antimicrobial, so more anti-infection medications. In some settings, if someone's having infections or their status or they've gotten CAR T, I actually may recommend giving them antibody transfusions, so antibodies from other patients in the area to help fight whatever circulating. The medical word for that is IVIG, intravenous immunoglobulin. But it's controversial. We actually are still figuring out how best to manage this, because there are some risks with doing all these interventions. And some patients, I have plenty of patients who are have immunoparesis or hypogammaglobulinemia in terms of their blood work, but no infection whatsoever. So it's not that simple, and I think we're still trying to figure out how best to tailor our level of support for immunoparesis to what the patient actually has.